Acute respiratory distress syndrome. In 1967, the first published case series of 12 patients with ARDS have been published. They had an average age, which is the oldest age was 43, so a relatively young age. The reported causes included the lung contusion in about 4 cases, viral pneumonia in other cases, abdominal trauma, acute pancreatitis as general causes for the occurrence of the ARDS. In 1994, there was another definition by the American European Consensus Conference on ARDS that was divided the ARDS into acute lung injury and ARDS. Both of them had an acute onset. Both of them had bilateral infiltrate on the chest X-ray, and both of them you should exclude the presence of cardiogenic cause for pulmonary edema, and here it was by pulmonary artery wedge pressure less than 18 millimeter mercury, or a clinical evidence, absence of clinical evidence of left atrial hypertension. Acute lung injury would be if the PaO2 PF ratio less than 300, and if it is less than 200, it will be an ARDS. And here there was regardless of the level of PEEP. PF ratio, to estimate the PF ratio, it includes the PaO2 divided by the Fio2. If a patient on 100% Fio2 achieved PaO2 of 120, this means that the PF ratio is 120 divided by 1, so it's 120 PF ratio. In a patient with PaO2 of 80 on an Fio2 50%, it will be 80 divided by 0.5, that equal 160. The PF will be 160. In 2012, the Berlin definition, which is the latest definition that we have till now, was similar to the previous definition with some minimal changes. They applied some items to discuss, including the timing, imaging, origin of edema to exclude the presence of cardiogenic cardiac cause for this edema, and the level of oxygenation. Due to the absence of difference in the management between acute lung injury and ARDS, these names were deleted, and it all becomes an ARDS with grading for mild, moderate, and severe ARDS. Timing, it includes 1 week from the non-clinical insult. It includes the acute development of the worsening of the respiratory symptoms. There is a bilateral opacities, not fully explained by effusion or collapse of nodules, and the absence of edema. The origin should be excluded, the cardiac origin, either by echocardiography or other parameters to exclude hydrostatic edema. And we should know that in many cases there is an overlap and there is a combination between the cardiogenic and non-cardiogenic pulmonary edema. In terms of oxygenation, in all items, the PEEP or CPAP should be equal or more than 5 centimeter water, and if the PF ratio is less than 300, but it's more than 200, it's mild. 100 to 200, it is moderate, and less than 100, it is severe ARDS. This is the classic imaging of the ARDS. The causes of ARDS include both pulmonary and extrapulmonary causes. The main cause in the pulmonary causes is the presence of pneumonia. Other causes include the inhalation injury, aspiration, pulmonary contusion, fat or amniotic fluid embolism, and near drowning. The main extrapulmonary cause is the sepsis. Other causes included the pancreatitis, trauma and blood, transfusion-related acute lung injury, drug overdose, and hemorrhagic shock. From these causes and risk factors, some lung injury prediction scores have been developed. One of them that we show here that included the high risk factors and giving points to every risk factor present. Shock, aspiration, everyone had 2 points. Presence of sepsis, 1 point. And other factors including pneumonia, high risk surgery, either abdominal surgery, cardiac surgery, aortic surgery, high risk trauma, traumatic brain injury, smoke inhalation, near drowning, lung contusion, multiple fractures. Everyone has points, and these points are to be added together to give a score. The higher the score, the higher the incidence of development of ARDS. Normally, the alveoli, terminal bronchioles and the alveoli have the bronchial epithelium, and this bronchial epithelium is important for acting as a scaffold for the terminal bronchioles, maintaining them open. There is an alveolar macrophage. There is type 1 pneumocytes, who are characterized by being flat cells, and they are responsible for the gas exchange. They represent 90 to 95% of the pneumocytes, and they cannot replicate. The type 2 pneumocytes are granular cells, represents 5 to 10% of the alveolar cells, and they secrete surfactant, and they can replicate and they can differentiate to type 1 pneumocytes. There is the capillaries and the vascular endothelium and its basement membrane. So finally, the alveolar capillary membrane, which is responsible for the gas exchange, will include the vascular endothelium, the basement membrane, the interstitium, and the type 1 pneumocytes. The deoxygenated blood passes toward the capillaries, where the gas exchange occurs according to the pressure gradient, with CO2 going to the alveoli and oxygen going to the capillaries through the interstitial space. And then the oxygenated blood will go out. The fluid passage through this interstitial space depends on the Stirling forces, which including the hydrostatic pressure. The hydrostatic pressure is the pressure pushing toward the interstitium, faced by the oncotic pressure, which is pressure pulling from the interstitium to the capillaries. The end result will that we will have some fluids in the interstitium. However, these fluids will be drained through the lymphatics. To maintain these spaces narrow, to allow for adequate gas exchange. The occurrence of the ARDS will start by activation of these macrophages. Macrophage activation either occurs locally, if in case of pulmonary causes for the ARDS, as the invading microorganism if it's an infection, or at the inhaled gases if it is an inhalation injury, and etc. In case of extra causes, there will be an inflammatory cascade, and this inflammatory cascade will include the recruitment of the activated neutrophils, which will release the cytokines that cause the activation of the macrophages. Finally, Those activated macrophages will release chemokines and cytokines, which in turn will recruit and activate the neutrophils, and these activated neutrophils in the circulation by these chemokines will migrate into the pulmonary circulation, and they will release the cytokines, including the tumor necrosis factor alpha, interleukin 1, interleukin 6, reactive oxygen scavengers, proteases, and inducible nitric oxide synthase, which will produce the nitric oxide. This will result in number 1, breakdown of the bronchial epithelium. Number 2, there will be destruction of the type 1 and type 2 pneumocytes. There will be an accumulation of a hyaline membrane that cause thickening of the alveolar capillary membrane. There will be accumulation of a cellular debris and accumulation of protein-rich fluids inside the alveoli that cause impairment of the gas exchange. Destruction of the type 2 pneumocytes will result in destruction of the surfactant and decrease in the surfactant formation, protein-rich fluid accumulation in the alveoli, and increase in the fluid in the interstitium that exceed the capacity of the lymphatics, and accordingly there is more accumulation of the interstitial fluids. There will be also an activation of the coagulation pathway through the activation of the tissue factor and extrinsic pathway activation and von Willebrand activation and von Willebrand factor, and the fibrinolytic activity increase in the fibrinolytic activity. This will result in the development of microthrombi inside the pulmonary microvasculature, and this may be the cause of the development of the DRCs. The net result will be a ventilation perfusion mismatch. Normally, these alveoli will be aerated, and the microvasculature will have, or the capillaries will have the deoxygenated blood to pass through it and be oxygenated and release the carbon dioxide, and then getting out the oxygenated blood. If we have this deaeration of these these alveoli, this will result in absence of the ventilation, or we can see the decrease in the ventilation of these alveoli. And normally, this is to be associated with the hypoxic vasoconstriction of these capillaries, and to be associated with a similar decrease in the perfusion, to have a normal or fixed ventilation perfusion ratio. But actually, what happens during ARDS and in sepsis is the development of the systemic vasodilatation caused by the activation of the inducible nitric oxide synthase and the formation of large amount of nitric oxide that will result in the vasodilation of these capillaries and the increase of the perfusion despite a matching decrease, and this will result in decrease in the DQ. This is known as the dead space ventilation. On the opposite side, in cases of pulmonary embolism, for example, if there is an occlusion of these pulmonary capillaries and there is no perfusion passing in the capillaries, resulting in a significant decrease in the perfusion, whether the ventilation is normal, and accordingly the BQ will be increased, and this is known as the shunt ventilation. These are the two types of the BQ mismatch or ventilation perfusion mismatch that we can face, and we can see that here we will have a dead space ventilation. We discussed here the first stage of development of the ARDS, which is the exudative phase. This is to be followed by the fibroproliferative phase, where there is accumulation of the fibroblasts, and these fibroblasts will form type 1 and type 2 collagen fibers, and these collagen fibers will accumulate inside the alveoli. Also, this is to be followed by the proliferation of the type 2 pneumatocytes and their differentiation into type 1 pneumatocytes, and finally the development of apoptosis and the phagocytosis of the activated neutrophils and reabsorption of the accumulated fluids to have the resolution phase of the ARDS. Mechanically, the ARDS will result in decrease in the compliance of the lung. The compliance of the lung is the ability of the lung to accommodate for the air inside. If the lung is a balloon, if the pressure inside can accommodate large amount of fluids to be given, of air or gas to be inhaled inside without much change in the pressure, so this lung is compliant, and this is the normal function of the lung, and accordingly the compliance here is the change of the volume per the change of the pressure. Changing large volume with small changes in the pressure indicates that the lung is okay and the compliance is okay. In case of ARDS, the mild increase in the volume will be associated with higher increase in the pressure because the lung is stiff. So small volume increase will be associated with large pressure increase, and accordingly the compliance will be decreased. The volume here is the tidal volume that you give, and the pressure here is the driving pressure inside. Driving pressure, which is the plateau pressure minus the peak. And we will discuss this again later. When we will discuss the management of the ARDS, we will have some management strategies, and we will discuss which of these factors could be effective and which is not. Importantly are the corticosteroids, the fluid management strategy, mechanical ventilation strategy including the tidal volume, the PEEP, prone positioning, the use of neuromuscular blocking agents, the inhaled vasodilators, nitric oxide, and the use of the extracorporeal membrane oxygenation and extracorporeal carbon dioxide removal. We will depend upon the guidelines on the management of acute respiratory distress syndrome that's published in 2019, and these guidelines mainly considered the reviewing the review articles and meta-analysis. In all their decisions, they had a meta-analysis of different studies. In the meta-analysis, you will get access to the raw data for every patient of these studies, and add the raw data of different studies together and reanalyze statistical analysis, new statistical analysis, putting in consideration the outcome that you will consider. And the main outcome that we have would be mortality. The effect of every intervention on mortality. So if you have an intervention 1 compared to intervention 2 in terms of mortality, they describe them in terms of what's called the relative risk. The intervention 1 is the study intervention. Intervention 2 could you say the control. So you have relative risk of using this intervention 1 compared to intervention 2 in determining the outcome, which is mortality. If this relative risk, for example, is 0.9, this indicates that the intervention 1 use was associated by 10% decrease in the outcome, which is here could be mortality or other outcomes. But this is not the important. The important, which is called the 95% confidence interval of this relative risk. Because when I say that there is a 10% decrease due to relative risk of 0.9, if this 0.9 was associated with 95% confidence interval of 1.2 and 0.4, for example, so this means that I have, yes, a mean decrease in my risk by 10%, but I am 95% confident that this decrease might be range from a 60% decrease to a 20% increase. So I don't know finally it's decrease or increase. There is a probability that there is an increase in the risk due to this intervention 1. And this indicates that I am not able to have a decision if this intervention is effective or not, because the confidence interval lies on the both sides of the 1. However, if the same value of 0.9 confidence risk, relative risk, was associated with 0.95 and 0.8 confidence interval, this means that I am 95% confident that the reduction will be, the mean reduction is by 10%, but it ranges from 5% reduction to 20% reduction, and so by the end there is a reduction. So this will be a significant, and I can have the decision that this intervention is effective. On the other hand, if I have an intervention that resulting in 1.2 mean relative risk with confidence interval of 1.1 to 1.25, so this is significantly increasing the outcome, which is could be mortality, could be other outcomes, could be beneficial outcome, could be a survival outcome, and this would be benefits. By the end, this is a significant change. But if the relative risk is 1.2 with the confidence interval of 4.9 to 1.25, this is not significant difference. To use this concept in the using of the corticosteroids, here are the outcomes. The outcome here is the mortality, the on-hospital mortality. Here it is the hospital or 6-day mortality, and here the outcome is the occurrence of the adverse events with the use of the corticosteroids, and here is the adverse events if it's post-ICU cognitive function. These are the outcomes, and these are the two groups, the control placebo groups and the intervention groups that use the corticosteroids in the cumulative in the studies. Those 326 patients, they are not in one study, they are in different studies that have this meta-analysis. So the mortality here, we have a relative risk of 0.62. This is good. This is 40% or 30-something% decrease in the mortality with the use of corticosteroids. But what is more important is, as we told, the confidence interval. It's from 0.23 to 1.26. So you are not confident that you are decreasing the mortality. You may increase the mortality, and accordingly, these changes in mortality are not significantly statistical. Similarly, in the hospital and 6 days mortality, the corticosteroids, the change were not significant, and also in the adverse events, there was no decrease in the significant decrease in the adverse events or increase in the adverse events. And accordingly, these results does not recommend the use of the corticosteroids in ARDS. We can say that there is no statistical findings in the previous studies that support the use of the corticosteroids in the ARDS. Accordingly, the recommendation statement that the use of the corticosteroids in established ARDS should be the subject of suitably powered multi-center randomized controlled trials with long-term follow-up. He cannot say that you don't use corticosteroids. The corticosteroids have proved efficacy in many randomized controlled studies, but when these meta-analyses showed no significant change with corticosteroids. And here we can use the corticosteroids, the dose that we all know, the solumedrol or solumedrol 1 to 2 milligram per kg per day, but we should know that this is not totally approved medication for the use in the ARDS. Another important findings is the fluid strategy. Again, in the outcomes of mortality, up to 6-day mortality, there is no significant difference between conservative fluid strategy compared to liberal fluid strategy. But it's important here to show that in the adverse events of the need for renal replacement therapy, there is the use of conservative fluid strategy was associated with a significant decrease in the need for the renal replacement study. This was based on single study. It is not, they didn't found multiple studies to do a meta-analysis. In this single study, the use of the conservative fluid strategy was associated with a significant decrease in the need for renal replacement therapy between the mean decrease when it is 0.71, so the mean decrease is 29% decrease in the need for renal replacement therapy. Their confidence interval from 1% decrease to 50% decrease according to this confidence interval. So they suggested the use of conservative fluid strategy in patients with ARDS. The conservative fluid strategy included or identified by some negative balance during the first week of admission. Before discussing the recommended ventilatory strategies in ARDS, let's discuss or revise some basic concepts. If there is a representation of the airways and the lung, so the flow of air in this airway depends upon the length of the airway, the viscosity of the air, the radius of the airway, and the pressure gradient. All these factors are fixed in press-to-press findings. However, the important here is the presence of pressure gradient. If the pressure at the proximal airway is higher than in the alveolar pressure, then the air will flow into the alveoli, representing the inspiration, and vice versa. If the pressure in the alveoli is higher than that in the proximal airway, the air will flow from inside to out during expiration. And the pressure changes in the alveoli will depend on both the volume administered and the compliance of the respiratory system. The second thing is related to in volume controlled ventilation. In volume controlled ventilation, we will give some preset tidal volume at a preset flow rate. Let's say 500 milliliter at a flow rate of 60 liters per minute. When you revise the pressure curve, giving this tidal volume will result in increase in the proximal airway pressure. Basically, the ventilator will measure the airway pressure at the presence of the sensor, the proximal airway pressure here. So it will increase to a peak level, and the rate of increase will depend upon the flow rate. A flow rate of 60 will be different from flow rate of less than 60, but it will reach a peak level. Then it will decline passively according to the pressure gradient that's present, back to the basic level. This is the pressure level. This is the inspiration and this is the expiration. The flow curve equivalent to this will include, during the administration there is a flow from outside in, and this flow the flow rate will depend upon the presetting values. You will start by a maximum flow of 60. So at the start of inspiration, this is the start of inspiration, the flow will increase to 60. It will either maintain as 60 or decline if you, according to the preset you applying to the ventilator. Then the flow will go back to 0 at the end of inspiration, and the expiration start passively by maximum flow at the initial phase and then decline to 0 by the end of the expiration. This is the inspiration and this is the expiration. The expiration, at beginning of the expiration, the pressure inside the alveoli is the maximum, so the flow will be maximum. There is a pressure gradient between the alveoli and the proximal airway pressure is maximum, and as air go out, the pressure decrease in the alveolar pressure will progressively decrease, and accordingly the pressure gradient will decrease, and accordingly the flow will progressively decrease. This is the peak inspiratory pressure, simply, which is the maximum pressure recorded in the proximal airway. But at this peak inspiratory pressure, there is a flow present here, and so this cannot be represented to the alveolar pressure. As there is flow going from one point to another, this means that the pressure here is higher than the pressure here. The only way that I am sure that and I'm measuring the pressure here. So if there is flow, this means that this peak inspiratory pressure is higher than the alveolar pressure. How much I can't know. The only way to make this proximal airway pressure equivalent to the alveolar pressure is the absence of flow. So if there is no flow, this means that the pressure here is equal to the pressure here. So if you stopped flow here at the end of inspiration, this will result in plateau in breathing. And then when you open the plateau, the pressure will decline again. This is the plateau pressure, and this plateau pressure is present when there is no flow. So it should be represented here by a period of no flow, and then the expiration will start. As there is no flow, so the pressure in the proximal airway pressure equals the alveolar pressure. So the plateau pressure can represent the alveolar pressure. In the same way, if I have this flow pattern, which is maximum flow, and this flow pattern, this means that at the beginning of the inspiration, there was a flow. It was not a zero. There was a flow from in to out, which means that the pressure in the alveoli at the end of expiration, the pressure here was positive. So it's a positive end expiratory pressure, which is known as the intrinsic PEEP. But can you measure from here how much is it? You cannot. At that time, despite the plateau or the pause that's applied during inspiration, you will have a pause at the end of expiration. When you have this pause at the end of expiration, this means that at the time of the end of expiration, the pressure will equalize between the proximal airway and the alveoli, and accordingly the pressure will elevate by the value of the intrinsic PEEP that can be measured. So applying pause at the end of inspiration will help you to measure the plateau pressure. Applying pause at the end of expiration will help you to measure the O2 PEEP. There are some pressures which are important to be monitored during mechanical ventilation. Number one of them, as we told, the plateau pressure. The plateau pressure is the alveolar pressure that represents the pressures that may endanger the alveoli. The plateau pressure should be less than 30 centimeter water. But also the cyclic changes of pressure inside the alveoli is important. The pressures that make the alveoli open and close. The alveoli open, so the pressure difference that changes the geometry of the alveoli is known as the driving pressure, is also important. Driving pressure is the pressure, maximum pressure inside the alveoli during inspiration, which is the plateau, and the minimum pressure inside the alveoli during expiration, which is the PEEP. Either a PEEP is zero or you applied an extrinsic PEEP, whatever it's reading. So the plateau pressure minus the PEEP pressure is known as the driving pressure, and this is very important pressure which cause cyclic changes in the pressure inside the alveoli, and that may result in the injury of the lung, and one of the factors that affect the ventilator-induced lung injury during mechanical ventilation, and it should be less than 15 millimeter mercury. Let's revise this model of the lung with ARDS. The alveoli in this area are collapsed alveoli, and accordingly the volume, when the volume is given here, it will cause some pressure increase to have a compliance of X. If I apply the PEEP in this lung, I could open some of these collapsed alveoli, and the alveoli collapse will be lesser, and the aerated lung area will be larger, and accordingly the compliance will be improved. So applying an external PEEP could improve the lung compliance. This could be represented by the pressure volume curve. The pressure volume curve, in the early phase, there will be a much increase in the pressure in relation to small change in the volume, and this is represent an area of low compliance, which is caused by the collapsed alveoli. When these collapsed alveoli are opened, this is an area of the lung where the compliance is the best. And finally, there will be an over-distension of the alveoli when they are filled with much air, and so again the minimal change in volume will result in a large change in pressure. We want to apply a tidal volume and a PEEP that make us working in this part of the curve where the lung had the best compliance. This is not easy to be identified to get your best PEEP that you will want to work on. But to simplify, if you have a representation of the compliance by the plateau pressure, so at this point of PEEP, you have this plateau pressure of X. If you applied a level of PEEP and this PEEP caused that the plateau was the same or even decreased, this means that this PEEP only opened the alveoli and does not cause the over-distension. However, if the applying more PEEP caused an increase in the plateau pressure equivalent to your PEEP, the added PEEP, this means that you reached the over-distension. The use of low tidal volume, which is represented by 6 milliliter per kg of ideal body weight, is considered one of the few interventions that proved a significant improvement in survival in ARDS. Despite the 60-day mortality revealed no significant changes, however, the in-hospital mortality was improved significantly by about 20% reduction in in-hospital mortality with the use of the 6 milliliter per kg body weight. And in terms of the adverse events, there was the presence of barotrauma, there was no difference. If this improvement of the low tidal volume was because of the low tidal volume or because of this low tidal volume caused lower pressure, this is an unanswered question. Again, the low tidal volume, here compared low tidal volume with high PEEP to high tidal volume with low PEEP. The addition of the PEEP level here to be studied, and it was showing that the use of the low tidal volume with high PEEP again was associated with better mortality. And the presence of adverse events showed no significant difference between the two strategies. So the recommendation is the routine use of lower tidal volume for management of patients with ARDS. So it's important to apply your initial ventilatory management. First, you should estimate the predicted body weight, and all your estimations of the tidal volume depends on the predicted body weight, which is measured according to either of these equations. Initial setting is 6 milliliter per kg predicted body weight for the tidal volume, and the respiratory rate is will be set to have a minute volume, minute ventilation of about 5 to 10 liters per minute, but not more than 35 beats per minute. Or you can observe during the increasing the respiratory rate, you will observe the flow pattern, and all through that you have a flow without auto PEEP, so you can continue so long you have reached the baseline and no flow point at the end of expiration, this means that you don't have an auto PEEP. But if when you increase the rate, you observe that the flow started to be present during expiration, so you should decrease the rate at this point. This means that you started to have some auto PEEP. The level of the Fi2 and the PEEP will depend on your targets of saturation and PO2, and the levels of the tidal volume and respiratory rate will depend on your targets of pH and PaCO2. And don't forget that you should monitor your plateau pressure and driving pressure continuously to evaluate your dangerous pressure not to be reached. In a study that evaluated the high PEEP versus low PEEP, found that there were no significant difference in terms of the mortality and in-hospital mortality and 28 days mortality. So you should evaluate the PEEP according to the effects of the PEEP that we discussed a few minutes ago, and the side effects of the PEEP, which are represented by the presence of the decrease in the venous return and its hemodynamic compromise, and occasionally, as we told, if it caused overdistension of the alveoli and caused more decrease in the more overdistension of the alveoli, and this might result in pulmonary hypertension also. So in subgroup analysis, in the same meta-analysis for patients with moderate to severe ARDS, when the PF ratio was less than 150, the high PEEP was associated with better survival. And also in the subgroup analysis in patients with PF ratio less than severe ARDS PF less than 200, the PEEP was effective, with no changes in the incidence of the parotrauma. In these trials, they used the high PEEP considered from 14 to 15.6 millimeter mercury centimeter water, compared to from 8 to 10 in the control or low PEEP group. So your average PEEP could be of about 14-15 centimeter water. So the guidelines suggested the use of high PEEP strategies only for patients with moderate or severe ARDS, where the PF ratio is less than 200. And there is a famous table for the Fio2p tables, and we should know that our target saturation in those patients is 88 to 95%, and our target PO2 55 to 80 millimeter mercury. If you had a patient with an Fi2 of 1, so your PEEP level would be 18 to 24. This is the lower PEEP, higher Fi2, and this is the higher PEEP, lower Fi2. There are some changes between them. When you are in one level, you will be in 24 PEEP. Then you will start first to decrease the PEEP to 22, and however the Fi2 is still 1. When you reach 1 and 22 and the saturation and the PO2 are in your targets, so in the next step you will decrease to 0.9 and you will remain in 22, then 0.8 and remain in 22, and then you will fix the 0.8 and decrease the PEEP to 20, and so on in this table, either from the high Fi2, high PEEP2 with recovery, or if there is deterioration, you will have in the opposite direction. The recruitment of the alveoli is opening the collapsed alveoli. The mechanism is by adding a PEEP of 30 to 40 centimeter water for 30 to 40 seconds, and then to go back to your baseline PEEP. As we told, you have a very important targets for the plateau pressure to be less than 30, and for the driving pressure to be less than 15 centimeter water, and the pH in the average to be more than 7.3. We told how to measure the plateau. To revise, the plateau will have either the machine will measure it spontaneously, or sometimes the machine will give you the opportunity to have an end inspiratory pause. When you have an end inspiratory pause, you can measure then the plateau. When you subtract this plateau minus the PEEP, applied PEEP, this is the driving pressure. When to measure, number one, at least every 4 hours of patients with ARDS, you should measure these pressures. And if you change the parameters, you should measure these pressures. If the plateau pressure is higher than 30 centimeter water, you should decrease the tidal volume by 1 milli per kg steps to reach a minimum of 4 milliliter per kg. If the plateau pressure is low, it's from 25 to 30 centimeter water, and the patient is synchronized and good, don't increase the tidal volume and don't change. But if the patient is an air hunger or have dysynchrony, you can increase the tidal volume by 1 milliliter per kg steps to reach 7 to 8 milliliter per kg, considering the plateau pressure is less than 30. But consider not only the plateau pressure, because if you have a patient with a plateau pressure of 25 and his PEEP is 0, this is not in the target, before his driving pressure is 25. So if a patient has a PEEP of only 5, so his maximum plateau pressure should be 20, not 30. So this limit of the plateau pressure should be synchronized with the limit in the driving pressure. This limit of the plateau pressure is considered if the driving pressure is within the allowed limit of 15 centimeter water. If the plateau pressure is less than 25 centimeter water, then the tidal volume is less than 6 milliliter per kg. At that time, we'll increase the tidal volume until reaching the target of 6 milliliter per kg. Your pH goal is 7.3 to 7.45, and this is called the permissive hypercapnia. And the pH, if the pH is lower than the 7.3, but higher than 7.15, you can increase your respiratory rate until the pH is higher than 0.73, but maximum respiratory rate 35. If the pH is less than 7.15, increase the respiratory rate to 35, and here you are nearly reached your maximum targets or maximum efforts. You may give sodium bicarb, and here you may think about the use of ECMO. During the weaning process, you should have a readiness for spontaneous breathing trial test. If your Fi2 is less than 4.4 and PEEP less than 8, or Fi2 less than 0.5, PEEP less than 5, and the patient has acceptable spontaneous breathing efforts, he is hemodynamically stable with no vasopressor support and neuromuscular blocking agents, At that time, you will allow him a spontaneous awakening trial and a spontaneous breathing trial at CPAP less than 5 centimeter water with pressure support less than or equal 5 centimeter water and FI2 less than 0.5. And if the patient is tolerated, you can assess for the tolerance for 2 hours. If the saturation is higher than 90% and the PO2 more than 60, the spontaneous tidal volume higher than 4 milliliter per kg, respiratory rate less than 35 per minute, pH is higher than 7.3, there is no respiratory distress, and this respiratory distress is not only respiratory, re-elevation of the heart rate by more than 120% of the baseline, the accessory muscle use, abdominal paradox, sweating, dyspnea. If considered to be tolerated, then you can extubate the patient. If not, you will resume your pre-settings. The use of neuromuscular blocking agents. Statistically, we can say that the use of the neuromuscular blocking agents improved the survival and decreased the mortality, either the ICU mortality and 20-day mortality and even the hospital mortality, with no changes related to the acquired weakness. What is the possibility of the cause of this? Because if you allow the patient to have spontaneous breathing, it will be difficult, very difficult, to control his breathing as the target 6 milliliter per kg predicted body weight of the tidal volume. Such patients will have a high respiratory drive, and this high respiratory drive will allow the patient to have increasing in the what's called the pressure swings of the lung. The pressure swings of the lung, that's represented by a large tidal volume, and these pressure swings of the lung will cause what's called the patient self-inflicted lung injury. So when you apply the patient on mechanical ventilation, it's required yearly to have him sedated and paralyzed to control his breathing and avoid the changes or swings in the transpulmonary pressure, which cause the patient self-inflicted lung injury. Before using mechanical ventilation, there is the high flow nasal cannula. The high flow nasal cannula, you will set the FI2 and it starts from 0.2 to 1. The flow rate, it's maximum of 60 liters per minute. The concept behind the high flow nasal cannula is that those patients with ARDS, but it's only in mild ARDS. So in patients with mild ARDS, those patients will have a high respiratory drive and a high respiratory flow. The normal subject have an inspiratory flow of about 25 liters per minute, but might increase during exercise to more than 100 liters per minute. So if you apply a flow which is equal or higher than the flow required by the patient, this might help him to rest his respiratory muscles and so reduce the respiratory efforts. So applying a high flow rate will give this advantage by matching the inspiratory, the already high inspiratory flow. It will deliver a high FiO2. However, if you applied a high FiO2 with a flow which is lower than the original patient's flow, this high FiO2 will be mixed with the air and will cause that the FiO2 that reach the patient is lower than that you set in the machine. Through increasing the flow rate, it will provide some sort of PEEP, but this PEEP will not be more than 4 centimeter water. by applying the high flow, it causes a washout at the proximal airway and decreasing the dead space, and it will reduce the respiratory efforts. But the drawbacks, it will only deliver small amount of PEEP, and the PEEP here cannot be measured. During the use of the high flow nasal cannula, it's important to monitor for the success or the probability of failure of the high flow nasal cannula. And this is used by using the ROX index, which is the measurement of the fraction of SpO2 over the Fio2 to be divided by the respiratory rate. For example, if the SpO2 is 98, Fi2 75%, and respiratory rate is 25, so 98 divided by 0.75, then divided by 25 will give you a 5.2. If this ROX index, which to be measured after 1 hour, 2 hours, 6 hours, and every 12 hours later on high frequency nasal cannula, if it's higher than 4.88, this is a little risk for intubation. If it's less than 2.85, this indication is an indication for intubation, and in between you should have close monitoring to consider the success or failure of the high flow nasal cannula. The use of non-invasive ventilation in the ARDS have some debates. To know, we have two modes for the non-invasive ventilation, either the CPAP, and in the CPAP you apply the continuous positive airway pressure, and the patient will have his efforts in between. However, the BiPAP, where you apply an EPAP, which is expiratory positive airway pressure, and an inspiratory positive airway pressure, these are two pressures that the patient will inspirate in between. The CPAP is used in patients with hypoxia only or obstructive sleep apnea, and this mode is used if the patient has a problem with the CO2 retention to allow ventilation in addition to oxygenation. You can set the machine of the Fio2 from 0.21 to 1, the PEEP 5 to 8 centimeter water, and higher PEEP cannot be used due to the leak in the oropharyngeal, the oral masks, and the pressure support of about 7 to 10 centimeter in the BiPAP level. It will deliver preset Fio2. It provides PEEP, provides pressure support to unload the respiratory muscle, monitoring the tidal volume. However, it has skin ulcers, air leaks, difficult delivery of high PEEP because of the leaks, high respiratory drive. And the high respiratory drive and transpleural pressure, transpulmonary pressure are very important items in this non-invasive ventilation. Few slides ago, we discussed that the value of the neuromuscular blocking agents was to control the breathing and to avoid the large swings in the transpulmonary pressure that were the cause of the patient's self-inflicted lung injury. This cannot be done with the non-invasive ventilation. So in patients with non-invasive ventilation, if they have a high respiratory drive, you will find that they have a high tidal volume, which is if higher than 9.5 milliliter per kg of the predicted body weight. This indicates a probability of failure, because this indicates that the patient has large swings in the pressures and in endangering his lung by inducing the lung injury. Accordingly, for every patient on non-invasive ventilation, you need to monitor for the HACOR score. This is to be monitored after 1 hour, 2 hours, 6 hours, and then every 12 hours. HACOR, H for the heart through the heart rate, A for the acidosis, including the pH, consciousness level, oxygenation, and the respiration. If the score is higher than 5 to 6. This indicates a high probability of failure of non-invasive ventilation and might need for intubation and invasive ventilation. The use of prone positioning during the ARDS, in the overall mortality, there was a significant improvement of the mortality with the use of the prone positioning. But there are two subgroup analyses that revealed a more beneficial effect. Number one, it is a subgroup analysis of patients with prone positioning. In addition to lung protective ventilation, there was still a significant improvement in survival in those patients. However, if prone positioning was used without the lung protective ventilation, there was no difference in the outcome in those patients, which is very important also the duration of the use of the prone positioning. In the sub-analysis of patients with prone positioning of less than 12 hours per day, there was no effect on the mortality. However, if the prone positioning was used for 12 hours or more, this was associated with a favorable outcome. The effect of the prone positioning might be attributed to the improvement of the ventilation perfusion mismatch. In the patient on his back, there is the lung, the dependent parts of the lung are more diseased and they have more collapsed alveoli, and at the same time they have more perfused due to the effect of gravity. When you put the patient in the prone positioning, this will shift the, this is to simplify the process, this will shift the perfusion to the more ventilated areas of the lung, improving the ventilation perfusion mismatch. In terms of the Cyto-Adverse Events, it was clear that the adverse events were higher, significantly higher in patients with prone positioning. But during sub-analysis, the higher adverse events revealed the endotracheal tube displacement, the presence of pressure ulcers, and the venous access loss. However, the other adverse events, like the pneumothorax or the cardiac events, were not significantly higher in patients with on prone positioning. Accordingly, the guidelines recommend not to use the prone positioning for all patients with ARDS, but prone positioning is recommended to use for at least 12 hours. It's important, it's at least 12 hours to use the prone positioning in patients with moderate to severe ARDS where the PF ratio is less than 150. So, the most important two interventions which have proved efficacy in treatment of ARDS, including the lung protective strategy in the ventilation using the low tidal volume of 6 ml per kg, and the more important is using the targets of the plateau and the driving pressure of less than 30 centimeter water and 15 centimeter water respectively. And the other thing is the use of the prone positioning in patients with PF ratio less than 150, and this prone positioning should be continued for at least 12 hours and might be more. The use of extracorporeal membrane oxygenation during ARDS had mortality benefits. It was seen that in the mortality, all over the mortality was better in patients with who had ARDS, who had ECMO compared to the usual care. However, also the adverse events were markedly increased with the use of ECMO. The guidelines don't recommend for routine use of ECMO for all patients, but it's a salvage therapy, the use of ECMO with lung protective mechanical ventilation in patients with severe ARDS as a salvage strategy, and there is severe ARDS defined in these studies of the ECMO according to the Muri score more than or equal 3. Muri score depends on the Fi2-PF ratio, PO2-Fi2 ratio, that given 4 points, 4 points for chest X-ray, 1 point for every quadrant involved in chest X-ray, 4 points for the PEEP, less than 5, 6 to 8, 9, 11, 12, 14, more than 14, 4 points finally to the compliance, and measurement of the compliance is the tidal volume divided by the driving pressure. And then you can calculate all these points and to be divided by the 4, you have 4 domains here. So for example, let's have an example in this patient with PO2 60 millimeter mercury and Fi2 100%, PEEP 10 centimeter water, plateau pressure 38 centimeter water, and tidal volume 420 milliliter. Chest X-ray have infiltrates in 3 out of 4 quadrants. In this patient, the PF ratio will be estimated as 60 over 1 equal 60, which is less than 100, so it has score of 4. The PEEP level 10 will have it's in the range between 9 and 11, so has a score of 2. The compliance will be 420 milliliters divided by the difference between the plateau pressure and the PEEP, which is 28. This give 15, and so the compliance is below 19, and this gives score of 4. Chest X-ray have 3 out of 4 quadrants. This gives score of 3. This to be divided 4, 6, 10, 13. 13 to be divided by the 4 domains will give 3.5, and the Muri score here is 3.5. Muri score more than 3 will be indication of severe ARDS that is indicated to have ECMO. Alternatively, the extracorporeal CO2 removal showed there was no meta-analysis that described the use of the ECOR in ARDS. However, some descriptive studies that only showed the mortality to be 27 to 75% with the use of the ECOR. So the recommendation related to the extracorporeal CO2 removal in ARDS is that this is a point of study and point of research that required multi-center randomized controlled trials with long-term follow-up and economic analysis. The value of the potential value of the use of the extracorporeal CO2 removal is allowing the use of extra low tidal volume to minimize the ventilator-induced lung injury, as the problem with the use of the low tidal volume is the occurrence of respiratory acidosis, which will be abolished by the CO2 removal. To achieve this extra low tidal volume, some authors use the high-frequency oscillation. High-frequency oscillatory ventilations require very low tidal volume at a very high frequency to be oscillation. However, in the from the research point of view, it has no effect, no significant effect, neither on ICU mortality or third-day mortality, and also there was no significant effect related to the occurrence of barotrauma. In addition, there was importantly significantly higher oxygen failure in patients with the high-frequency oscillation ventilation, and so the panel recommended against the use of high-frequency oscillatory ventilation in the management of patients with ARDS. The inhaled vasodilators, the use of inhaled nitric oxide. the inhaled nitric oxide with the potential use of causing vasodilation in the ventilated alveoli, allowing for improving the VQ mismatch to improve the oxygenation. Also, it has an anti-inflammatory effect, and it could correct the pulmonary hypertension, which can complicate both the ARDS itself and the use of mechanical ventilation. However, its effect is transient. It lasts for only 96 hours, and the effect is greater only if there is a pulmonary hypertension, and the high pressure administration of the nitric oxide may result in vasodilation, or not only for the ventilated alveoli, but it might cause vasodilation of the unventilated alveoli, and this could worsen the PF ratio. From the clinical point of view, again, the use of the inhaled vasodilators showed no significant impact on the mortality, and it showed more deleterious effect in terms of the increase in the significant increase in the renal dysfunction with the use of the inhaled vasodilators or inhaled nitric oxide. The panel don't suggest using inhaled nitric oxide in patients with ARDS. However, in another guidelines also published in 2019, published in the Annuals of Intensive Care and Management of Acute Respiratory Distress Syndrome, they suggest that the inhaled nitric oxide can be used as a salvage therapy in patients with ARDS with deep hypoxia despite implementation of protective ventilation strategy, prone positioning before the use of the ECMO. To summarize, as we call that the most important two interventions in patients with ARDS that has strongly in favor of its use are the low tidal volume of 6 milliliter per kg of the ideal body weight, and the plateau pressure less than 30 centimeter, and the driving pressure is very important limitation also, less than 15 centimeter water. They are the most important, and together with the prone positioning for patients with PF ratio less than 150, and also it's to be more than 12 hours. These are the two most important interventions that prove to be effective in patients with ARDS. And strongly against, because its drawbacks, because its side effects and lack of efficacy, is the use of high frequency oscillation. Also weakly in favor is the use of the conservative fluid management, the use of higher PEEP together with the low tidal volume, and the use of the neuromuscular blocking agents, and the use of ECMO. Here it is required more research related to the corticosteroids, ECOR, and the inhaled vasodilation could be weakly against, or we may need also further research.